Neurology is a study of the few, and that's really what holds neurology back. So we don't have 20,000 heart attacks. I mean, you go to stroke, you have 800,000 a year. That's a pretty good number, right? But then you go to subarachnoid hemorrhage, which is a form of hemorrhagic stroke. Well, there's only 40,000 of those nationally. That makes that a much more difficult thing to study because a third of those people die at onset. Then you take a third of those numbers away. How many years do I have to study to do a 16 or 20,000 patient study to differentiate a 4% improvement in one outcome over another? So cardiology has the advantage of big numbers and lots of medications, right? But we have no therapies for brain injury, even zero.
What is the value proposition for those hospitals, and what's the benefit for them in the long run?
Yeah, that was one of the reasons why we started our service in the community hospitals, really to explore, what would be the value proposition. And selfishly, one of our goals was to stop transferring patients that didn't need to be transferred.
Of course.
Right? And especially within our health system. So this is one of our affiliate hospitals sending to the big house, right, a patient that didn't really need to be transferred. And if you think about the number of times you're worried about seizures in somebody, it's way more often than you actually find them. And so we wanted to promote retention at that site of the appropriate patients. And we felt like with a phone call, we could probably help the medical ICU providers, which were mostly anesthesia and internal, critical care trained. We could walk them through, how to manage these patients, which is high comedy. We can have a conversation, when you call a hospitalist or a medical doctor and you say, well, there's periodic discharges and sharps in the left frontal quadrant, and then you stop and there's this awkward pause and then they're going to ask you like, well, what do I do now? So you can't just be an EEG reader. You're going to end up, helping manage these patients. But I think, I think those, the value to them became retention of a large number of those patients. And then identification of patients that really needed a higher level of care. Those people who had already failed multiple agents and were now in refractory status. We didn't find any of those because they're a rare bird anyway, during the 3-year period that we published on. But utilization went up, and we successfully managed all but one case of status, by doing feedback to the team on the ground there. The one case that wasn't managed was a fatal case, so they withdrew care before we stopped the seizures. But I think that was a good lesson learned. And then the unexpected value proposition for that center they became a referral center. So I run our Telesroke program. I ran that for many years and started it here at Duke. And it's not uncommon to have a consult for stroke where their onset was a seizure or some kind of episode where they syncopized or felt lost consciousness. And a subset of those patients really needed to just be screened for underlying seizures, right? And those hospitals can't keep them because they don't have that service, right? So they can't retain those patients where they should be able to, but they can't. And so I would send those to our community hospitals. So they saw an increase in their ICU census.
Oh, wow.
As a result of having that capability. I didn't have to bring them all the way to the big house where there was no room anyway.
Yeah.
I could send them to our community affiliate, and then guess what? I'm the guy reading the study anyway.
Right.
So I think that worked out really well for them. So it was a ability to better utilize their ICU for cases that could easily be managed locally. Even if it wasn't, even if it was a stroke, if there were seizures associated with that's a complex stroke patient, easily managed at our affiliate site, and so.
And there's risk to transferring patients anyways, right? So it's
not only risk, but it's a cost, right? It's a health system cost, particularly if you're transferring within your health system. So in our assessment of we saved $150,000 in transfer costs over those 3 years. That would have been paid out of the health system, right? The health system has to foot that bill. It's their own, EMS agents that are going over, picking these people up, bringing them over for no reason at all. We can manage them there. And then you add to that the retention. I think we showed a direct contribution margin of like $100,000 for that whole cohort, $70,000 for the seizure ones, the ones that were actually seizing. So there was money to be, that was retained at that facility for keeping those patients there and managing them locally, as well as the cost reduction. So when you added all that together, it was almost $250,000 swing
Yeah.
by having that. So I think the value proposition is not only in better care. We mentioned before sort of the equating cardiac arrest patient prognosis and being able to make that assessment more objectively with overt data per guidelines, and creating equivalence in terms of level of care for those patients, but also the ability to expand the capabilities of that center to be able to adequately manage folks that couldn't be kept at smaller other community hospitals. So I think there are a variety of enhancements and value propositions to at least some of the medium-sized hospitals in the country. I don't know that I would. You have to be able to do something if you keep these patients, and so I don't think critical access or some of these really small hospitals should want to keep seizure patients, but you want to know that that's the problem, so that you're only transferring patients that need another facility's care. And so I think understanding that and having that capability to screen and keep the ones that you can take care of and identify the ones you can't is really important. And that's kind of what's not happening now.
Wow. So how does a presentation of seizures in critically ill patients really differ from other hospital settings?
I guess I don't know that it's necessarily different. I think it's kind of a different journey. Right. Everybody kind of talks about the patient journey now in medicine. I don't really know what that means, but I guess, when you think about how their journey starts or begins, people with epilepsy, one of the most common is non-adherence or running out of meds or, having breakthrough seizures that exceed their normal breakthrough seizures, but they have a history of epilepsy. So when that patient comes in, they're often known to the health system. They have this in their chart, and you can reload them on the meds they take at home. You can check levels. There's kind of a standard process, and they're likely to respond, to those meds in most cases, unless they have known refractory epilepsy as an outpatient, and then even then, you kind of usually are able to get them back down to their normal seizure burden fairly quickly. Whereas people that you discover seizing in the hospital is a whole different animal, because they're there for another reason. They're usually there because they're septic, or they're there because they have heart failure, or they're there because they came in for surgery and now they're not waking up postoperatively. So you've got a very disparate group of patients who weren't there because they have epilepsy. So It's always kind of surprising when you discover these seizures, and then their responsiveness to medications varies widely. So you might give a load of drug and poof, gone, done, no problem, you're done. Quit thinking about it, right?
Yeah.
And then others, you load that first agent and nothing happens, and you're like, how's that? Are you sure it went in? Are you, is that IV working? Yeah. And then you add the second agent and they're still seizing, and you're like, wow, this is going to be a problem, right?
Yeah.
So I think that's the major difference. Is really it's we talked about before, like clinical context and the history. Knowing that somebody has epilepsy guides you down a pathway of enhancing, checking on the levels of their current drugs, using their current medications, maybe even reaching out to their outpatient epileptologist for what they were thinking. Because a lot of times this will happen when they're transitioning drugs because they were having side effects, or they wanted to go off drugs for one reason or another and try something else. And so, there's typically a reason why somebody with epilepsy has enough breakthrough seizures to warrant a visit to the ER, because often they know they don't need to come for every seizure.
Right.
And so, when we see those patients, there's kind of a definitive pathway for epilepsy patients that doesn't exist for this whole other population, that we discover.
How often do patients who experience seizures in the ICU actually develop epilepsy? Let's say when they go home after a TBI, for example, they were known or seen to have seizures caught on the EEG in the ICU. How prevalent is it for patients who actually go home from these experiences to actually develop true epilepsy?
Yeah, it's a great question. It's been looked at in a couple of different ways. So back in the 90s, there was a lot of research on post-TBI or post-traumatic epilepsy, looking at those rates. And a couple key features are the severity of injury. So the more severe the injury, the higher the later risk. It looks like that risk for at least closed head or confined injury is up to maybe about 20% of folks will develop a subsequent epilepsy after trauma, versus penetrating injury where it could be as high as 50% of those folks. So if you have like a gunshot wound or something that penetrates the skull and the dura and gets into the brain tissue itself, those folks have a much higher risk long term. So in TBI, it's pretty well defined. In stroke, we see it. We definitely see probably in the same range. It's probably 10 to 20% of folks who have cortical injury as a result of their stroke will be at risk for subsequent epilepsy. What's interesting is it's just not as clear. And I always tease the residents, the board exam answer for what is the most epileptogenic tissue in the brain, it's temporal lobe. So just whatever when you're on the board in the exam, temporal lobe. But in the hospital, the reality is it's occipital lobe.
Okay. And why is that?
And I think there's just there's a difference in the blood-brain barrier and the permeability of that. That's why you see these hypertensive encephalopathy cases. They're called PRES, posterior reversible encephalopathy syndromes, and so there's just a predisposition. And what I see is what I learned from the early electrophysiology I did as a graduate student is that denervation or loss of excitatory input leads to spontaneous bursting activity in the cells that remain. Every brain cell has its own favorite firing rates. And so if you deprive it of its primary excitatory input, it will revert back to its firing rate based on its remaining inputs from other regions. And so when that becomes oscillatory, you end up with these, hyper resonant or asynchronous discharges. And I think the occipital lobe is obviously massively innervated by excitatory input. It's our main visual center. And so when you have strokes that disrupt some of those pathways, then you basically denervate a highly organized columnar, structure of its primary excitatory input, and I think it just predisposes. And so we just tend to see, posterior quadrant seizures quite often. I feel in acute injury settings.
So if there's two patients that actually come in, or they go in to see a neurologist, and one patient has a genetic disposition to epilepsy, and one came from the ICU, TBI, the patient that I just asked you about, do you approach, or would a neurologist approach the treatment differently, or even the testing process? How do those two patients differ whenever you're looking at the whole story?
Yeah, I point to my outpatient actual epileptologist for a lot of that stuff. There's constantly looking at, different drugs and new ways. There's some new approaches to Lennox-Gastaut, for example, genetic, pediatric epilepsy syndrome. So I think, I leave that to those epilepsy experts. That's not kind of my area of expertise. In the hospital, we use all of the same drugs, but we use them sort of indiscriminately,
right.
So there might be an indication that this drug is really good for, generalized epilepsies versus other. And really, I think our approach is you use the least interacting, least offensive drugs first. So Keppra is a favorite because it just doesn't interact with a lot of other things. It's easy to give in high volume. And so usually that's sort of the first one in. But then, a lot of us will try to mix mechanisms. So the presumed mechanism of action for these drugs, you might start to hit AMPA receptors to reduce excitability, or augment GABA to increase inhibition function. And, so you start to add drugs that you think will, in combination, affect. And then, a lot of times you let the EEG drive the decision, right? So if you add a drug and nothing happens, that's the first drug I'm going to take off as soon as I add another one that might do something, right? So I try to avoid polypharmacy by sort of being aware of what impact I've had on the ongoing seizures. And the outpatient guys don't have that advantage, right?
Right.
And so, I think that immediate feedback on the seizures that we discover in the hospital allows us to be a little bit more dynamic and rapid in our titration of drugs to get control. Whereas on the outpatient side, you're fighting side effects, right? People get dizzy, they don't feel good, they get sleepy. Well, I got a comatose patient in the ICU on a ventilator, so I'm not worried about dizziness as a side effect, right? So, I have a little bit more free reign to cycle through meds fairly quickly and find a combination that works for that patient.
How accurate would saying that whenever you're approaching a brand new patient in the ICU who might be experiencing subclinical seizures, how much of a guessing game is it for you? And then you kind of go from there, you adjust accordingly?
Yeah, I don't think we make too many presumptions about causation. I mean, again, in clinical context is everything. So if this person had a stroke 2 years ago and they're presenting now with new onset, syncope at home with recrudescence of their stroke symptoms, and they come up to me and we get an imaging that doesn't show any new ischemia, no new stroke, they probably had a seizure. So I'm suspicious. We hook them up. We find seizures. Miraculous, I'm right, right? And so now you just treat them. So we start with Keppra, or we start with something that's relatively well tolerated. There are certain populations where you would back off and you'd say, well, somebody who has cognitive impairment or has disinhibition, those aren't great patients to give Keppra because it's got that side effect. So I might try something else, first. And so there's always a need to look at the individual patient. But generally, we kind of hierarchical go through, Keppra, then Vimpat, then something else, into ketamine. Ketamine's kind of a new big thing, seems to work in some and not in others. So we have the luxury.
Why is that, do you think?
I think it has to do, presumably ketamine is working through its NMDA receptor activity and reduces excitability. So there's probably a subpopulation of folks where you have that imbalance. And there's this whole concept in epilepsy that seizures are either a breakdown of your prevention mechanism, so seizure prevention mechanism, or an out of control generation of hypersynchronous activity, right? So either are generating seizures or you're unable to stop them,
right?
And so, these are described sort of in this kind of wild definition of epilepsy or seizures now with T1 and T2 and how long can you let people seize before they get injury and whether there's a mechanism, So I think it probably speaks to the underlying etiology, but that's not been super worked out. And it's not always clear, from the clinical, like it isn't like ketamine always works in one condition and it never works in this other. It hasn't really maybe been used enough or studied enough to be able to say that. But in my personal experience, I haven't had a ton of success with it, but when it works, it's really impressive.
So in my 20 years in neurodiagnostics, I see these disciplines that seem far more advanced as far as what we know about them, right? And neurology seems to lack behind on just the knowledge, and maybe it's because of the brain's complexities. But what do you think are some of the barriers for the advancement or what we know about neurology compared to all these other disciplines?
Neurology is a study of the few. And that's really what holds neurology back. So, we don't have 20,000 heart attacks. I mean, you go to stroke, we have 800,000 a year. That's a pretty good number, right? But then you go to subarachnoid hemorrhage, right? Which is a form of blood, a hemorrhagic stroke. Well, there's only 40,000 of those nationally, right? So that makes that a much more difficult thing to study because a third of those people die at onset. So then you take a third of those numbers away. How many years do I have to study to do a 16 or 20,000 patient study to differentiate a 4% improvement in one outcome over another? So cardiology has the advantage of big numbers and lots of meds, lots of medications, right? But we have no therapies for brain injury, zero. Right. So not only do I not have a drug to study yet, right. but I have a very complex system that's in small numbers. So it's a daunting, if you're a drug company and you're like, man, I want to create a drug for stroke. That's fantastic. Well, unless it's a lytic agent where we know what the numbers are per year in eligibility, then you've got to fight for a known drug already on the market, right? That's a losing. The only company that could do that was the one who was making the competitive drug already, right? So they're willing to cut into their own margin to run a trial, right? Yeah. But yeah, I mean, if you're going to create a drug, it's going to be on a small population. It's going to take you years. So the level of enthusiasm there among big pharma is not great. And the few studies that have been done, both in Alzheimer's disease and in stroke, have all been negative, right? Stroke is just a giant graveyard of pharma, and so, I think that those are barriers for us that keep us on the lag compared to, say, cardiology or even internal medicine or other folks where there's lots of new diabetes medicines. But I will say, there are bright spots within neurology. So in terms of disease modifying therapy, MS has been our biggest win, right? I mean, for sure, there are disease-modifying therapies within MS. I think Parkinson's is starting to see maybe some potential opportunities there. So there are I think myasthenia gravis, understanding that autoimmunity, treating that aggressively. When I was a resident, we used to have one or two of those patients on service all the time, and I don't see, I never see them unless they're new onset or something else causes them to be hospitalized. We just don't see myasthenia anymore. The neuromuscular group is very, very adept at maintaining those patients outpatient and controlling their disease. So I think there are a variety of areas in neurology where we've excelled and had great successes, and other areas where we lack an intervention, and so therefore we continue to lag behind. Even neurocritical care. I mean, when I started, I finished fellowship. My first year as faculty, even as a fellow, like last year fellow, I attended the third ever Neurocritical Care Society meeting, right? So as a practice, as a specialty, it's really been created in my lifetime, in my career, right?
Yeah.
So neurocritical care is only about 20 years old. Now, if you listen to Tom Black gives this great lecture on the history of neurocritical care, and it goes back to the iron lungs of the polio patients,
Oh, wow.
right? So actually, neurologists were the first intensivists because we were the only group that was willing to take care of the post-polio iron lung patients. And then with the advent of positive pressure ventilation, then anesthesia took over because it was being used for surgical procedures. And so then anesthesia became the main purveyors of critical care.
Wow.
So it's an interesting history if you go back.
Wow.
So neurology gave up its opportunity to own ICU care many, many years ago.
Fair enough.
But has come full circle, to have its own role in patient care.
Yeah. So I come from a hospital that when I first started, we did paper EEGs. That was actually only in 2002. We were just a little bit behind, but paper EEGs, you're limited to just the 20-minute study. And I would go into the hospital, I'd go into the patient's room, I'd hook up the patient for 20 minutes on this paper EEG. I would, tear off the perforated paper. I'd go down to the neurologist and he would sit there and he would flip. He was old school. And I think that's one of the reasons we didn't go into digital EEG. But, that was what we had at the time. We didn't have long-term EEGs. We didn't have 24-hour, 72-hour EEGs. So my question for you is, what are the benefits of a long-term EEG? Why can't you just go into a room, do an EEG, make sure the patient isn't in status or whatever, and treat the patient from there?
Yeah, great question. I actually got to read paper EEG as a resident.
Did you really?
Yeah, at the VA. They were still running paper at the VA.
So you know what I'm talking about.
I know exactly what you're talking about. That's the whole derivation of the double banana montage, right? It's based on what the text would do. But So that's a great question. I tip my hat to the Columbia group who looked at this question very early on. They pulled all their recorded data and looked at everybody that had a seizure in their recording history, their recording data set, and said, how long did the recording have to go to find those seizures, right? And everybody that seized. And what they showed was that the sensitivity of a 20-minute EEG was pretty low. It's like less than 20%. Maybe for in some studies it's been a little bit higher, maybe closer to 40%, but very low. So you're missing a lot of patients who are seizing. And you can imagine if you're having one seizure an hour, that's pretty frequent. Mm-hmm. I wouldn't want to have one seizure an hour and have that go undetected, but it gives me an hour to do a recording and not see it.
Yeah.
So that's really the problem with doing routines. And so, how long do we need to record? Well, when I set up our ICU EEG program, I said, well, if we don't see a seizure in 24 hours, that's probably not why this person's in a coma. Mm-hmm. And from a resource utilization perspective, we had to draw the line somewhere. So, running 4 days or something to get 99% of everybody was excessive. Mm-hmm. So you can hit about 80 based on their data, and it's been probably confirmed in several other publications. But you can detect over 85% of everybody who's going to have a seizure on EEG within 36 hours or so. And that's kind of how it works. You hook people up, you try to get the full 24 hours, and then you say, okay, you can unhook them. And then the tech's like, whatever, I'll get over there eventually, and unhook them. And so 6 or 8 hours more goes by and you get about 30 hours, mm-hmm. Per study anyway. So that's been kind of our practice since we set it up. And it's really based on that data that you want to make sure that you're capturing seizures in everyone who that might be contributing to their current clinical condition. And if you don't see them within 24 hours, then they're happening. If they're happening infrequent, or they start later, right? And so you can always hook them up again later and screen for that again if you've now gone down the road of all these alternative diagnoses and not found anything. You can always come back. But that's to me that's why routine is basically useless in hospitalized patients. I mean, the only time I ever suggest we use it is on new onset seizure, right? So if you're going to get, if somebody totally recovers to baseline, has their first ever seizure, 20-minute EEG, MRI, see them in clinic, right?
Yeah.
That's kind of the role for it in those ER or hospital-based patients. But, I just don't see any reason to do it. So I always tell the fellows to, call the team that orders that, because it's probably put in wrong. They just ordered the wrong thing.
Right.
And try to get them to convert it, because it's just not going to help the consult team. It's not going to help the primary team. It's not going to help the patient. It's not going to answer the question.
Yeah.
So they really should do a full 24-hour study.